Ahora tengo el gusto de presentar al doctor Mark Mannis. Él es el jefe de departamento de córnea en la Universidad de California en Davis, en Sacramento. Y el doctor Mannis nos va a hablar de la cirugía de queratoprótesis, resultados a largo plazo y complicaciones. Él tiene de las series más largas publicadas en la revista de córnea y va a compartirnos su experiencia. Adelante, doctor Mannis.
And over the past 5 years, we have developed a sizable cohort of patients whom we followed longitudinally. I'd like to thank the UC Davis KPRO research team, who over the years have helped us look at, analyze our results and determine the outcomes of the Boston keratoprosthesis in our hands. There are a number of reasons for failure of a Boston keratoprosthesis, and I will spend a little time expanding on the complications that Dr. Vargas pointed out. One of these is bioincompatibility, and then the others include secondary complications, such as infection, glaucoma, either secondary glaucoma or worsening of existing glaucoma, retinal detachment, and retroprosthetic membrane formation. There are a variety of approaches to artificial cornea production. One is to produce a device which is biointegratable. One is to construct tissue ex vivo and use it as a prosthesis. And the third is to use materials which are not necessarily integratable, but are biotolerated. An example of biotolerated prostheses are the erstwhile Cardona prosthesis and currently the Boston keratoprosthesis. The purpose of what I report to you today was to look back and evaluate the long-term outcomes after the placement of a Boston type 1 keratoprosthesis to determine the types and frequency of complications that developed postoperatively. We did a retrospective review of all KPRO surgeries done at UC Davis from May 2004 through May 2010 and used as a criterion for success postoperative vision. At the time, at the time of publication of this material, the number of eyes was 40. Since then, the series has expanded considerably with an average follow-up time of 33 months. The primary indications for keratoprosthesis in our series were multiple failed corneal transplants, including patients with previous keratoconus, herpes simplex virus, and corneal dystrophies, and patients who had had remote chemical or thermal burns. You can see also that we implanted patients with aniridia, with ocular cicatricial diseases, and rheumatoid arthritis. What were the complications we've encountered? One, which Dr. Vargas mentioned, was retroprosthetic membranes, periprosthetic infections, sterile corneal melts, and glaucoma. And I put glaucoma in red because this is probably the most common and serious complication of the Boston keratoprosthesis. Let's look at the retroprosthetic membrane issue. Virtually all of these patients develop some retroprosthetic opacification. As in a case like this, you can see it's quite dense. Many of these membranes are actually vascularized. We saw this in roughly 55% of our patients. Of these, 10 were treated with YAG laser membranotomy, and 5 required pars plana membranotomy in conjunction with our retina service. If the retroprosthetic membrane is not visually significant, one can observe it. If it becomes visually significant and is amenable to the laser therapy, YAG laser membranotomy can be performed, but it has to be performed very carefully because it's tightly opposed to the back of the prosthesis, and it's very easy to injure or damage the prosthesis. Pars plana membranectomy can also be performed, but is a substantial undertaking for the patient. It should, however, be done when there is vascularization or contraction of the membrane, which can pull off the ciliary body and lead to hypotony. Periprosthetic infiltrates, either infectious or non-infectious, occurred in about 15% of eyes. 12% of these patients, 5 patients, developed endophthalmitis secondary to periprosthetic infiltrates. In these patients, we aggressively manage them with cultures and sensitivities, topical and oral antibiotics, and in some cases performed subconjunctival injections. Extrusion of the K-Pro occurred in roughly 15% of the patients, usually secondary to an infectious or non-infectious periprosthetic melt. The major problem for us was glaucoma. We looked at vision loss in glaucoma in these patients, and glaucoma is either surgical compromise of pre-existing glaucoma or new onset glaucoma from the reconfiguration of the anterior segment. The closure with crowding of the anterior segment by the device, collapse of the trabecular meshwork, particularly in the aphakic K-pros, and residual iris stump in the aniridia, which will fold back and induce angle closure. And of course, all of these patients are treated with steroids, so steroid-induced glaucoma must also be considered. We looked at 35 eyes with glaucoma in our study. All patients were defined as glaucomatous, and we did central static visual field testing, peripheral kinetic testing, and retinal nerve fiber layer thickness measurements. The glaucomatous eyes with K-pros had significantly thinner retinal nerve fiber layers at the optic nerve head, significant constriction of the peripheral visual field, although it's difficult in all K-pro patients to get accurate field measurements, and decreased foveal thresholds. So the question arises, should glaucoma surgery be performed in all patients with a Boston K-Pro? It does increase the risk of infection and endophthalmitis if you put in a tube. There are problems with tube exposure, which I will show you. And even with glaucoma drainage devices, there's often progression of the glaucoma. 23 of our patients had pre-existing glaucoma. 11 of the patients had already had glaucoma drainage devices. You can see in these 2 graphs that preoperatively, patients with and without glaucoma had about the same vision. Postoperatively, the patients without glaucoma did slightly better. And then at further follow-up, the distance between the 2 groups increased with worsening of vision in the glaucoma subgroup. At the end of our study, 80% of our patients were being treated for glaucoma. And 7 of those patients developed end-stage glaucoma. 17 of the patients required glaucoma drainage devices. And of those, 58% of the devices eroded at the surface of the eye. You can see here a tube shunt with an erosion over the tube exactly where the contact lens, which is required for the Boston keratoprosthesis, sits at the tube. And so this becomes a problem. Also, even when a pars plana device is placed, you can get erosion of the Hoffman elbow at the edge of the contact lens. So patients who had glaucoma drainage devices that eroded ended up with much worse visual prognosis because of the need to remove the tube, secondary operations, and endophthalmitis. So glaucoma in K-Pro patients is difficult to diagnose prior to surgery. Intraocular pressure is very difficult to measure once the device is in. It's very hard to measure progression because of the difficulty of visual fields. And with glaucoma drainage devices, there are persistent problems with the anatomic situation of the glaucoma drainage device. Here you can see a distribution of visions preoperatively in our group, and you can see that most of the patients had count fingers, hand motions, or light perception vision. Postoperatively, in the lavender, you can see that the visions shifted to the left. So there was significant improvement in functional vision immediately following surgery. So most of our patients improved 3 lines or better with the surgery. However, half of them did not, and over a 3-year period, those patients with 2200 or better went from 60% to 29%. So there was a significant fall-off in visual acuity. This is a very busy slide, but if one looks at the institutions in the United States, which have substantial series of K-PROs, virtually all the results are similar. Most groups get very good visual outcomes initially. When one looks at corneal melts, they're roughly comparable, although you can see that UC Davis had a higher incidence of corneal melts than other programs. When it comes to retroprosthetic membranes, again, they're very similar, but you can see that Wills Eye Hospital had a much higher incidence of retroprosthetic membranes, and I can't explain why that is. If one looks at infectious keratitis, once again, UC Davis gets the gold medal, to use Olympic terminology. And when it comes to glaucoma, once again, UC Davis has the highest incidence of glaucoma. So you can draw many conclusions from this, either that we don't know how to do K-PROs at UC Davis, or that we're honest. And I think it's the latter. In conclusion, a high percentage of these patients get excellent vision improvement immediately postoperative. And I must tell you that I've been a great enthusiast of the K-PRO procedure. However, visual acuity declines over time, and one must weigh the advantage of the visual improvement after surgery against the long-term decline of vision, and the patient needs to be counseled in this regard. Glaucoma is a persistent problem, and we're working very closely with our counterparts in the subspecialty of glaucoma to help monitor these patients and to treat them appropriately so that they don't develop visually devastating complications. And with all of these complications, a relatively high percentage of these patients develop problems. Will patients benefit from K-PRO surgery? Undoubtedly. But as asked before, the selection of the patient has to be very judicious. The long-term prognosis is guarded, and it should not be undertaken without a team effort. So in our institution, all K-PRO patients, in addition to being seen by the cornea service initially, are seen by the glaucoma service and the retina service before the decision to perform a keratoprosthesis is made. So I submit to you that this is a procedure that certainly has a place in our armamentarium, but the initial effect of the keratoprosthesis, which is very dramatic, mustn't obscure the fact that these patients all develop complications in the long run. Thank you very much.
¿Alguna pregunta del público para el doctor Manis?
¿En qué casos utiliza el cálculo de la queratoprótesis para afaquia?
Is this working? Okay. The choice to put a keratoprosthesis in an aphakic patient really depends on, I think, the comfort level of the surgeon. You know, keratoprosthesis surgery really requires no different skills from those that we use in keratoplasty. The choice of the Boston K-PRO is for the pseudophakic patient comes in one size fits all. For the aphakic patient, one has to do axial lengths and determine the power of the prosthesis. In a patient with a good iris diaphragm, with relatively little vitreous in the eye, I think that an aphakic prosthesis is very suitable. If there is a significant iris derangement, then what I prefer to do is to put in a transscleral sutured intraocular lens at the time of capro surgery, and then use a pseudophakic implant.
Yeah, Mark, very nice talk. Have you seen a lot of retinal detachment in the cicatricial diseases? I saw a report by the Massachusetts Eye and Ear group, and they found an extremely high number of retinal detachment in those cases. We didn't see a lot in Brazil because we don't do a lot of Stevens-Johnson with Capro type 1. But have you heard about that, and do you think this happens?
In our series, we have not seen a predisposition to retinal detachment in that group. When I think of our retinal detachments, they really fall across the gamut of cases, including glaucoma, aniridia, previous grafts. So there's no propensity in our series to the patients with severe inflammatory ocular surface disease.
Nosotros estamos preparando nuestra serie y hemos tenido una incidencia alta de desprendimiento de retina. Sí. Especialmente se asocian bastante a la formación de estas membranas retroprostéticas. De hecho, estuvimos tan impresionados con ese hallazgo que cambiamos nuestro approach a la cirugía. Ahora todos los pacientes que van a recibir una queratoprostesis también hacemos una vitrectomía por pars plana al momento de la cirugía, y en pacientes que pensamos que tengan alto riesgo de tracción damos hasta endoláser en la periferia. Pero es un hallazgo muy interesante. Yo creo que puede estar relacionado a la tracción de las membranas retroprostéticas.
And tube shunt for all patients for the glaucoma? Do you treat patients?
We have a staged approach to this. If patients have pre-existing glaucoma, we put in a tube shunt. If patients do not have glaucoma, we generally put in a stage 1 Barvelt. So we put in the drainage area and then tuck the tube under the conjunctiva. Then if they develop glaucoma, we can go back and just put in the tube. The other group that we're just doing, I was talking with Luis Izquierdo before I gave my lecture, is that in an increasing number of patients, we're doing endocyclophotocoagulation at the time of the prosthesis implant if they have pre-existing glaucoma. So it's a very simple procedure. The glaucoma people come in through the limbus, put in the endocyclophotocoagulator. They will usually coagulate 50% of the processes, and then we do the keratoprosthesis.
¿En algunos casos es iridotomía parcial o total?
Sí.
When do you decide to use a keratoprosthesis versus do a limbal stem cell transplant in an aniridia patient?
It's a very good question. I am increasingly turning to ocular surface reconstruction as opposed to keratoprosthesis. The problem with aniridics, of course, is that it's almost always a bilateral stem cell deficiency. And finding a family member who doesn't have the disease is also difficult. So in aniridics, we're still moving primarily to Capro, but whenever we can do ocular surface reconstruction as opposed to Capro, that's our general approach with in unilateral cases with a conjunctival limbal autograft, a 3-month hiatus, and then either a Capro or a graft.
You know, I totally agree with Mark, especially because a lot of these aniridic patients are also young. And, you know, that's what I'm saying. I think the ideal patient is the older patient, bilateral blindness, from multiple graft failure and healthy ocular surface. When you put a K-Pro, I like to put it in a way, it's like you put these patients in a ticking bomb, because they're going to get complications. So younger patients, I would try to stay away from them.
Would you use a graft from a non-family member, or that's where you draw the line in terms of limbal stem cell?
I didn't hear the first part.
Would you take a limbal stem cell from another donor, not a family member?
Yeah.
Absolutely.
Okay.
Yeah. And our hope is that with the ex vivo expansion technology, we should be able to take it from the oral mucosa or other donors and use that as your main therapy for these patients.
And the trade-off, of course, is that patient who's getting an allograft is going to need to go on systemic immunosuppression. But if you look at Ed Holland's data on patients on systemic immunosuppression, they're really very good. And most people tolerate that extremely well with minimal side effects.
And by the way, Mark, in terms of your data, the honesty versus not knowing how to operate, I'm pretty sure it's the honesty factor.
Thank you. Thank you for the vote of confidence.
Bien, tenemos tiempo para una pregunta más antes de pasar a la siguiente
I think it's going
exposición.
to be the last one. What about the medroxypyroxidine? I mean, do you use as a regular medication treatment? I mean, in the post-op, medroxyprogesterone as a regular treatment in the post-op?
We are not using medroxyprogesterone, nor do we use doxycycline, which some people do. We've relied primarily on corticosteroids with, I think, pretty reasonable results. We've not found it necessary to use
How
them.
long?
Systemic corticosteroids for a short period of time. Topical corticosteroids generally ongoing until the inflammation is completely mitigated and healing has occurred. Then we keep them only on antibiotic coverage.